All right, let's dive right in. Today, we are cracking the code on cardiac, one of the absolute toughest topics you're going to face on the NCLEX. We're not just going to give you a list of facts, nope. We are going to give you a strategic preview of the framework you need to think through these questions the way the NCLEX actually expects you to. Let's do this. First things first, you have to understand this one concept. Every single cardiac question, whether it's a rhythm strip, a heart failure scenario, or a med question, it all comes down to one thing: perfusion. It's about getting blood where it needs to go. And the NCLEX is testing you relentlessly on whether you can protect your patient when that system starts to fail. And look, the stakes are as high as they get. Let me be totally direct. If you can't spot the rhythms that will kill your patient in minutes, you simply cannot pass this test. It's not just a skill they'd like you to have, it is an absolute, non-negotiable requirement for being a safe nurse.
And what about chest pain? Oh, the NCLEX loves chest pain questions, but they don't care that you can just identify it as a symptom. They want to know if you can figure out what's happening right now and what you must do in the next 60 seconds. It's a game of speed, timing, and priority. So why is cardiac such a monster for so many people? Well, it's because all the conditions kind of start to look the same when you're under pressure. It's so easy to get lost in the weeds and totally miss the big picture. Does any of this sound familiar? Mixing up stable and unstable angina? Or maybe you've memorized a huge list of symptoms, but you can't connect them back to that core idea of perfusion. Or that feeling when you know you missed the first right answer? These are the exact traps the NCLEX lays out, and it's why you need a different strategy.
And here is the absolute truth, the thing you have to get. This exam is not a vocabulary test. Memorizing definitions will not save you. The NCLEX is built to test one thing and one thing only. Can you make a safe decision and take the right action immediately? Okay, so let's pull back the curtain a little bit and give you a glimpse of the decision framework we use here at Exam Coaches. This is how you take that mountain of confusing cardiac info and turn it into a clear, predictable system. Check this out. On the left, you're looking at ventricular fibrillation. That is complete and utter chaos. It's a lethal rhythm, and it needs a shock like yesterday. But on the right, that's atrial fibrillation. Yeah, it's serious, it's concerning, but your patient probably has a pulse. The NCLEX demands that you know the difference in a heartbeat. So let's try it out. You see this rhythm on the monitor. It's irregular, you can't find any P waves, but the patient's vitals are stable for now. Before you jump to an action, what's the very first thing you need to recognize about this rhythm? What's the number one risk? Now let's apply that same framework thinking to chest pain. The NCLEX needs you to be a detective. Is the pain predictable? Does it happen when they walk up the stairs and go away when they sit down? That's stable angina. Or is it totally unpredictable, happening at rest, getting worse? That's unstable angina, and that's a massive red flag for a heart attack. Okay, quick thinking question. Your patient says, my chest pain is totally gone now that I'm sitting down. What does that one simple fact tell you about the perfusion problem, the supply and demand issue happening in their heart? Now, when things escalate to a full-blown myocardial infarction, you've got to act fast. We've all heard of the mnemonic, right? Oxygen, nitro, aspirin, morphine. But here's the trap. The NCLEX knows the order can change depending on the patient. They're going to test if you know the priority and the why behind each step. All right, here's a priority scenario. Your patient has crushing chest pain, and the ECG shows ST elevation. You know what that means. A STEMI, a complete blockage. You've already put them on oxygen. What is the single most critical goal right now? What does that phrase time is muscle really mean in this exact moment? Let's simplify another beast, heart failure. Forget memorizing a giant list of symptoms. We split it in two. If it's left-sided failure, think lungs. The fluid backs up into the lungs. If it's right-sided failure, think rest of the body. The fluid backs up everywhere else. You'll see JVD and edema. Left, lungs. Right, rest of the body. Simple. So let's connect those dots. Your patient gained 5 pounds overnight, and when you listen to their chest, you hear crackles. You've got a systemic sign and a pulmonary sign. What does that combination tell you about the failure in their perfusion system? Sometimes your job is just to spot a ticking time bomb. With an aortic aneurysm, that's exactly what you're doing. You need to know the red flags for a rupture. And trust me, they are not subtle. We're talking severe, tearing pain, signs of shock, a plummeting blood pressure. This is all about emergency recognition. Let's run a scenario. Your patient has a known AAA. They suddenly yell out, complaining of a 10 out of 10 tearing pain in their back, and you see their BP just drop off a cliff.
What's the only thing this can be, and what does it mean you have to do right now? Whew. Okay, we just ripped through 5 different cardiac conditions, right? They probably feel like totally separate topics you have to memorize, but they're not. They're all just different ways that one single problem shows up. Let's tie it all together. This is it. This is the master key. It's all about perfusion. Every single one of these conditions, from the electrical problems to the plumbing problems to the pump problems, they're all just different flavors of perfusion failure. Once you see that, everything starts to click into place. And here's that aha moment. See how it works? Dysrhythmias mess up the timing for perfusion. Coronary artery disease is literally a blockage that restricts perfusion. An MI is what happens when perfusion is cut off completely. Heart failure? The pump is just too weak to perfuse properly. It's not 6 different topics. It's one system with one focus. So what's the bottom line for you? It means you have to stop studying lists of facts and start building true clinical judgment. That is your strategic advantage on the NCLEX.
We don't just dump content on you. We train you for the skills the NCLEX actually measures. We train you to spot an emergency before it spirals out of control. We train you to prioritize when 5 things are wrong at once. And we train you to make the life-saving clinical judgments that define a great nurse. And I want you to burn this into your brain. The NCLEX isn't trying to trick you. It's trying to find out if you're safe. Once you learn to think with these frameworks, the safest choice becomes obvious. And the safest answer is always the right answer. Look, this was just a quick preview, a sneak peek at a much bigger system. We've shown you the approach, the full in-depth cardiac framework with every intervention, rationale, and priority you need to know. It's all waiting for you inside.